Thank you for joining me today, and please subscribe. In this video, we are going to learn more about social anxiety and SSRI medication, how SSRI medication can help or treat anxiety, social anxiety in transition age youth. We are going to define transition age youth, and we are going to describe the developmental characteristic that influences psychiatric treatment, explain the epidemiology, biological, pathology of a social anxiety disorder in youth, apply a DSM-5 diagnosis treatment to accurately diagnose social anxiety disorder. We want to evaluate the efficacy, safety, and tolerance of SSRIs medication in youth population. Also integrate with that is we are going to learn how to integrate cognitive behavior therapy with the SSRIs, family intervention, and pharmacotherapy into comprehensive treatment plan. So we are going to learn how to set up the comprehensive treatment plan by combining psychotherapy, pharmacotherapy, family intervention to support the youth in a social anxiety disorder. We are going to learn how to monitor the treatment response using valid rating scale and evidence-based follow-up strategy. We are going to learn how to address SI, manage medication, compliant transition of care, long-term relapse prevention. We are going to learn all that. So social anxiety disorder is formally referred to social phobia. It's one of the most common disorders affecting teenagers and young adults. It is characterized by persistent fear of negative evaluation and embarrassment, humiliation or rejection, social or performance situation. So teenagers are scared of that. So they withdraw from the society because they are having a social anxiety. They are worried about humiliation. They are worried about embarrassment. They are worried about negative evaluation from their peers or others. They are worried about rejection in the social or performance situation. The onset of typical social anxiety typically happens when the person is in the teen years and coincident with the major developmental transition involving identity formation, peer relationship, academic achievement, increase dependency. So it affects all that. Transition age, generally defined in between 16 to 25 years age. So when the child is when the child become a teenager between 16 to 25, they can develop social anxiety disorder that represent a unique developmental population. And during this period, patient transitions between teenager to adulthood, and it is transitions between pediatric to adult healthcare system, while stimulated negative education, they can develop negative in their education that can affect their education, occupation, and social contacts. Instead of social anxiety during this development stage is associated with impaired academic performance, social isolation, substance abuses, depression, SI, and reduction of occupational function. So this social anxiety will cause them to have social isolation, poor academic performance, poor occupational performance. They will misuse of substance. They will have depression. It will cause them depression. It will cause them to have SI ideation. So we want to support them with cognitive behavior therapy as a first treatment of social anxiety, and SSRIs serves as the first line of treatment. So SSRIs are the first line of treatment for social anxiety disorder, and also cognitive behavior therapy is the first line of therapy for social anxiety. And this treatment for moderate to severe symptoms, it helps them moderate to severe symptoms. Psychotherapy alone is not sufficient. So treatment decisions should be incorporated with developmental factors, patient preference, family involvement, caregiver monitoring. Side effects include the FDA box warning regarding increased suicidal ideation and behavior in the children and teenagers and young adults. So antidepressant medication has FDA box warning that warns this may increase the suicidal ideation for children, teenagers, and young adults. So you have to weigh the risk, weigh the benefit with the risk. Social anxiety disorder is the most prevalent anxiety disorder in youth. It is 7 to 10% in teenagers, 8 to 13 in young adults, and lifetime prevalence is 12%. Average age that develop social anxiety disorder is between 13 to 15 years old. More common in females than male, and persistently in adulthood. So it happens when the person is 13 years old, and it continue when they are older. I have seen adult patients with social anxiety disorder. So that happens when they were younger, and it continue. Developmental challenges patients commonly experience transition from pediatric to adult in healthcare. College, what caused the anxiety is some of these. College to vocational training. They are entering in the workforce. Increase independency. So because they were children, their family were taking care of them. When they become adult, when they take the responsibility, when they have to work, have to pay their bills, all that will cause anxiety. They have to deal with outside world, identity development, romantic relationships, financial responsibility. All that can affect the development of social anxiety and interfere with the successful navigating of the developmental tasks. Anxiety disorder involves dysfunctional with the circuit respond for fear process and emotional regulation. So they have a fear of social evaluation. They have emotional reactivity to the society. It affected their frontal cortex, interior circuit contacts, neurotransmitters. So social anxiety disorder requires mark fear of anxiety. It characterized by fear or anxiety about one or more social situation that involves scrutiny by others. They are worried that other people are scrutiny or judging them. Fear of acting in a way that will be negatively evaluated. So they want to be perfectionist. If you are worried about other people are judging you, that's not okay. If you are worried about other people are they are going to scrutinize you, they are worried about social situations, almost always provokes that anxiety and fear. Fear is disproportionately to actual threat. And the symptoms have been there 6 months or longer. That is the definition of a social anxiety. It is clinically significant distress and impairment of the function and an ability of the person to work, to have a relationship, to have a successful academic successful. Symptoms are not better explained by other psychiatric disorders. They are not using substance. There is no medical conditions that cause this anxiety. That is the characteristic of social anxiety. The differential diagnosis of society anxiety disorder, social anxiety disorder include normal developmental shyness, shy, general anxiety disorder, panic disorder, autism spectrum disorder, general depression disorder, avoidance personal disorder, substance-induced anxiety. So you want to do a comprehensive psychiatric assessment. You want to assess the history of the social anxiety disorder. When did that begin? You want to see if they have a developmental history of anxiety. You want to assess their academic performance, social function, family psychiatric history. You want to assess that. Do the teenager had a drama or adversary events that caused the anxiety? Are they using substance, drugs, alcohol, tobacco? What causes this anxiety? You want to also assess the medical conditions. If they have medical conditions that causes this anxiety, you want to assess the safety, SSI. You want to also assess the mental health status examination. You want to use the mental health examination and assess their appearance, behavior, speech, mood, affect, thought process, thought content, insight, judgment. Do they well groomed? How is their appearance? Are they well groomed? Do they are visible tensed? Are they anxious? Behavior. How is their behavior? Do they have a limited eye contact? So psychomotor, agitation. Speech, are they soft, hesitant, decrease response? Are they anxious? Are they telling you their mood is anxious? Restricted affect, is their affect restricted, apprehensive? Thought process, are they logical? Are they focused on anticipatory embarrassment? Thought content, are fear of criticism or humiliation? Is their inside usually intact? General appearance, you want to assess that. Screen tools and rating skill, you want to use social phobia inventory. You want to use the social phobia inventory. You want to use the Lubiwisi anxiety, social anxiety scale, general anxiety disorder, or GAD-7. You want to also assess depression. You want to use the PHQ-9 for depression screening. You want to also use the Columbus Suicidal Severity Rating Scale when indicated. You want to recommend or refer them to therapy, affinity-based therapy like cognitive behavior therapy, exposure-based therapy, acceptance and commitment therapy, family-based interventions, pharmacology treatment that include SSRIs and SNRIs, their performance, only social anxiety. Medication generally is avoid include the benzodiazepine. They can get dependency, so you don't want to start with that. There is a FDA box warning for all antidepressant medication is regarding of increase of suicidal ideation for children and behavior for children and teenagers and young adults, particularly the first week of the treatment or when the dosage changes. You want to discuss that the risk and benefit with the patient and the family. You want to develop the safety plan. You want to monitor closely during the treatment, initial or dose changing. You want to assess the emergency, agitation, behavior activation, SI. You want to monitor the treatment response. You want to evaluate the symptom severity, school work function, social participation, medication compliant, side effect, sleep, substance, SI, and initial follow-up is often scheduled 1 week to 2 weeks after the first medication with ongoing assessment based on the clinical response, based on how they responded to the treatment. So the SSRIs, the anxiety medication, continue treatment for approximately 12 months after the remission because it takes a long time this medication to work before considering increasing or stopping before you, so you can see the effects. While individualized decision is based on relapse risk, severity, comorbidity, and patient preference. Psychotherapy skills should continue to be reinforced through the treatment. I have a case study for you. We have 19 years old college student reports intensive fear of a classroom presentation, avoids social gathering, and experiences panic symptoms before speaking in the class. So his academic performance is declining because the participation is avoided. He's avoiding the participation. And when you assist him, social anxiety, you diagnosed him with social anxiety disorder, moderate functional impairment, no substance abuse, no SI, and the treatment plan is initiating the cognitive behavior therapy with gradual exposure exercise, began Zoloft using a low dose to start with and then gradually increasing it if you need to. But if it's effective, you don't have to increase that. You want to provide education regarding the delay onset of the therapeutic benefit that typically takes several weeks. You want to also educate the side effects and medication compliant. Social anxiety disorder frequently begins when the person is a teenager and often remains in the adulthood. Cognitive behavior therapy is the cornerstone of the treatment and should often available, should often encouraged. SSRIs are the first treatment for the social anxiety disorder, and you want to begin low dose of SSRIs. Improvement in avoidance behavior often lags behind. Reduction of physiology anxiety and encourage continued participation and exposure exercise. You want to encourage family involvement, coordination of transition from pediatric to adulthood. So the social anxiety disorder is a highly prevalent and impairing condition that commonly emerges during the teenagers and early childhood. It is significant developmental transition. Early recognition and treatment are critical to prevent long-term academic, social, and occupational impairment. Comprehensive care integration, accurate diagnosis, validated assessment tools, evidence-based psychotherapy, particularly cognitive therapy, cognitive behavior therapy, in conjunction with the psychotherapy. SSRIs remain the first line of medication class for moderate to severe social anxiety disorder. So, clinicians should individualize treatment, closely monitor the side effects and SSI during the antidepressant medication, support long-term recovery through collaboration, psychoeducation, relapse prevention, developmental appropriate transition plan. Please subscribe and join me in my next video. Thank you.